Howdy, y'all. This is Dr. Jeff Jarvis. I'd like to talk with y'all today about an important aspect of making intubation safer for our patients. Now, as y'all know, RSI, or rapid sequence induction, or rapid sequence intubation, depending on how you say it, is the use of both a sedative and a paralytic to facilitate intubation. Now, the literature is clear that the use of paralytics improves first-pass success rates, but it can also come at the cost of profound hypoxia. To avoid this, proper RSI includes adequate preoxygenation. After looking at the scientific literature on this topic, I learned that we often don't achieve adequate preoxygenation. My review of the literature identified several specific techniques that have been demonstrated to be effective. I put together a clinical bundle of care that is aimed at achieving appropriate preoxygenation to increase first-pass success without hypoxia. We implemented this bundle at my prior services, and we published a paper demonstrating its impact on avoiding peri-intubation hypoxia. We're now implementing this bundle here in Fort Worth. The short version of that study, it works. Now, in this video, I'm going to go over what the literature says about the extent of the problem, as well as the evidence for each specific component that's in our clinical bundle of care. I want you to understand why we're doing what we're doing. And then we're going to finish up by going over the results of that paper I told you about that shows the impact of that bundle on the peri-intubation hypoxia rates at Williamson County. Now, when we discuss this clinical bundle, we refer to the entire bundle as DSI, or delayed sequence intubation. Now, while this is a useful shorthand, true DSI is just one component of the overall bundle that we're going to be using. It's just easier to say DSI than clinical bundle of care. Now, before I jump into the literature and get all nerdy with you, I want to talk about a case. Now, I've changed any part of this story that might possibly identify the patient, but please know this was a very, very real case, and it was a case that had a big impact on me because I feel like I was personally responsible for this case. So we need to always keep in mind that the concepts we talk about here may seem abstract to us, but they are very real to the patients we're applying them to. And I think this story helps bring that to heart. Now, I want to share this story with you, like I said, because it deeply impacted me and the crew involved. And as you will soon see, it made a huge, huge impact on that patient and their family. All right, so here's the story. Mrs. Smith, obviously not her real name, is a 68-year-old wife, mother, and grandmother. She'd been feeling puny for a few days. Nothing specific, just not right. She starts to get a bit short of breath. Now, because of her history of multiple medical problems, getting a little short of breath isn't exactly unusual for her. She takes her albuterol inhaler, and she continues to take her daily furosemide, or Lasix, just like she's been prescribed. But otherwise, she doesn't call anybody because she doesn't want to bother anyone. Now, unfortunately, her breathing gets worse, and eventually it gets so bad that she feels like she has no choice but to call 911. A medic unit and field supervisor respond to her home, and they find her sitting up in the living room. She's tachycardic, she's hypertensive, she's afebrile. Her oxygen saturation is 90%. They put on a non-rebreather mask while they're assessing lung sounds. They hear some expiratory wheezes. They give her nebulized albuterol and ipratropium. Her pulse ox, unfortunately, does not go up. In fact, it goes down from 90% to 89% to 88% to 86%. The crew realizes the nebulizer alone isn't going to cut it, so they try to put her on CPAP. Now, unfortunately, Mrs. Smith is becoming agitated and confused. She starts trying to push the CPAP mask off her face. She isn't tolerating their attempts to help her. After a brief discussion, the crew collectively decides she has failed non-invasive ventilation, and they proceed to intubate using rapid sequence induction. So they push 2 milligrams per kilogram of IV ketamine, rapidly followed by 2 milligrams per kilogram of IV succinylcholine. Now, Mrs. Smith relaxes and becomes apneic as intended. She's lowered to a supine position on the ground, and the medics begin to intubate her using a video laryngoscope. Everyone's eyes are glued to that gorgeous VL display as what was anticipated to be an easy intubation becomes difficult. Now, I mentioned all eyes were on the display. Nobody, however, was watching the monitor. And if they were, what they would have seen is her pulse ox continued to drop, 86, 80, 75, 60. Mrs. Smith, who initially had a heart rate of 120, she's now getting bradycardic. Her heart rate is dropping faster and faster, 80, 50, 30, 0. Miss Smith is now in a systole. Recognizing this, the medics abort the intubation attempt. They start compressions. They ventilate with a mask. Her saturation gradually improves to 90% and they get pulses back. A second paramedic attempts intubation and is successful. Saturations rise to 96%. Blood pressure, pulse, stabilize. Whew. Man, the medics tell themselves, Mrs. Smith was very, very sick. Sometimes these things just happen. Nothing we really could have done differently. Fortunately, she has pulses back. All is well now. No harm, no foul. Right? Yeah, not so much. Unfortunately, Mrs. Smith never wakes up. She has permanent hypoxic brain injury, and she remains in a vegetative state. That means that her husband, her children, her grandchildren will never get her back. And all because of an unforeseeable and inevitable illness. Right? Was it really unforeseeable? Was it really inevitable? Was it? Mrs. Smith suffered a peri-intubation hypoxic cardiac arrest, a rapid sequenced death. This is not only predictable, it is preventable. By systematically changing the way we approach intubation outside of cardiac arrest, we can prevent this, and we can do everything we can to assure future Mrs. Smiths get to go home to their families. Now, I want you to take away 3 key points from this video. Number 1, peri-intubation hypoxia is common and it is harmful. Number 2, to avoid peri-intubation hypoxia, stop intubating hypoxic patients. And 3, use the preoxygenation toolbox to correct and prevent hypoxia. Now, in the rest of this video, we're going to cover the science behind each of these 3 key points. Each of the components of DSI and the supporting science is described here. So let's get to the first point. Peri-intubation hypoxia is common and it is harmful. Intubation has been a part of paramedic training since the very first national standard curriculum, way back in Freedom House days. Now, we typically teach this as a series of P's: preparation, preoxygenation, pretreatment, and paralysis. Unfortunately, most of these P's have been glossed right over both in training and in practice. Many medics, and physicians too, skip straight to the sexy part of inserting the endotracheal tube. They skip right over the preox, the preparation. This disregard for the fundamentals of preoxygenation has led to peri-intubation hypoxia to be common both in the field and in the hospital. Now, I'd like to share some of the literature that points this out to you. With a 2003 Annals of Emergency Medicine study of EMS RSI in 54 patients with traumatic brain injuries, they found 57% of those patients had at least one hypoxic episode during intubation, and the majority of these, 81%, were not hypoxic to begin with. And in the majority of those, the patients were felt by the intubating medic to be an easy tube. So it wasn't a function of these being difficult intubations. So what's a little hypoxia, you say? Well, it turns out that 9% of these patients also experienced hemodynamically significant bradycardia, like Mrs. Smith. In a 2018 paper, Walker and his colleagues in the state of Washington found 43% of patients undergoing EMS RSI had peri-intubation hypoxia, and 68% of those were severe hypoxia, 80% or less. The intubation attempt nadir, or low point, for half of those patients was 71, and the 25th percentile for that low point was 36. This means that a quarter of all intubations had a low saturation during intubation of 36 or less. Now, you'll remember that atmospheric oxygen is 21. It means like we're almost sucking oxygen out of the patient's body. These are low sats. And they're not brief episodes either. The median duration of hypoxia in that study was 2 minutes. That's 120 long seconds of hypoxia. And this was in an EMS system with an above average first pass success rate of 82. In fact, 70% of all desaturations occurred with first pass success. So what does that mean? Well, it means first pass success alone is not sufficient to prevent hypoxia. Now, I know a lot of my colleagues would have you think this is something that only happens in the field, that when that patient crosses the magical barrier into the emergency department, this never, ever, ever happens. Y'all know that, right? Right? Yeah, no, not so much. Unfortunately, it happens in our magic ERs too. This paper shows that in 166 emergency department RSI intubations, 36% of them experienced at least one episode of peri-intubation hypoxia. And of these, 93% were not hypoxic to begin with. So one thing I want to be clear about, and this is really, really important, these episodes of peri-intubation hypoxia, they are not a function of bad paramedics or bad physicians. It is really easy to admonish a clinician for allowing peri-intubation hypoxia, but it's unfair and it's self-defeating to do so. Please don't do that. As humans, we are prone to getting tasks saturated during critical events. Critical events like, say, intubating a sick patient. And just to be clear, we don't exactly intubate not sick patients. Well, that task saturation happens in the ER too, because humans. This 2016 Australian study of 100 directly observed ED intubations, they found physicians underestimated both how many patients had DSATs and how long the intubation attempt took. When asked, the clinicians felt like only 13% of patients DSATed, but the observers saw DSATs in 23%. They also completely lost awareness of time. They thought it took on average 23 seconds to intubate. In fact, it was almost twice that. This, again, is a function of being human, not of being a bad clinician. We're just not wired to both reliably intubate and monitor patients during an emergency. So we need to systematically change how we intubate if we're going to avoid this. And by systematically, I mean we need to change our systems. So the data we just discussed shows that peri-intubation hypoxia is common. But not only is it common, peri-intubation hypoxia is harmful, particularly in patients with conditions that don't tolerate hypoxia well, like, say, maybe brain-injured patients from TBI or from stroke. The odds ratio for death in these TBI patients with even one episode of hypoxia in this pre-hospital study was 3.9. Now that means the odds of death were 290% higher for patients with hypoxia than for patients without hypoxia. And this was not an isolated finding. It's not just a one-off study. There was a large state registry of TBI patients in Arizona, and they found the odds ratio of death in patients with hypoxia was 6-fold higher with hypoxia than without. This study also looked at the effects of hypotension, and they found that even one episode of hypotension was associated with a 340% higher odds of death. That equates to a 4.4-fold increase. Now, shockingly, the odds of death in patients with both hypotension and hypoxia, that was 13-fold higher than in patients who had neither. Hypoxia is also associated with hemodynamically significant bradycardia and cardiac arrest, like we discussed before. In an academic emergency department study, 2% of all RSIs had peri-intubation cardiac arrest, and over 80% were those from hypoxia. That means what happened to Mrs. Smith is not unusual. She got hypoxic, and this led to bradycardia, which led to hypotension, which led to cardiac arrest. So peri-intubation hypoxia is not only common, it's harmful. Now, you may have heard that intubation first pass success is important. You may have heard me say that. Why is it so important? Well, because failure to achieve first pass success is associated with an increase in adverse events. Well, what kind of adverse events, you ask? Well, I'm glad you asked that. The most common of these adverse events is peri-intubation hypoxia, the very thing we're trying to avoid. In a study of 1,800 emergency department intubations, the rate of all adverse events with first pass success was 14%. Now that rate increased to 47% with 2 attempts and 64% with 3 attempts. And as you can see, that is a very steep increasing curve. Take a look at this graph. You see that red line? That's the rate of hypoxia. That's the most common adverse event. 9.2% of patients with hypoxia, even with the first pass success. But that goes up to 38% with just 2 attempts. The odds of having an adverse event with each additional attempt goes up by more than 2-fold. Now, those are large odds ratios. Now, in addition to increasing the odds of adverse events, multiple attempts are also less likely to succeed. There is what I call a plateau point, above which further attempts are statistically futile. I did a study on this using a large pre-hospital data set, and what I found is for pre-hospital intubations using RSI, the plateau point is between 3 and 4, meaning after 4 attempts, further attempts are very unlikely to be successful. But as we've seen, each additional attempt comes at a clinical cost. So your actual attempt limit likely should be lower than that. And that's why we have limited the number of intubation attempts to no more than 2 per patient. Again, 2 per patient, not per clinician. It's our way of balancing the harm of additional attempts with the declining odds of success with each additional attempt. So if peri-intubation hypoxia is common and it's harmful, it sure would be nice if it were predictable too. Now, fortunately, that is often the case. If we look at this classic oxyhemoglobin dissociation curve, we can see how this is the case. Remember that the oxyhemoglobin dissociation curve is a plot of different pulse ox values at varying PaO2s, or partial pressure of oxygen. And as you can see from this curve, this is sigmoidal. In other words, it's S-shaped. It's not linear. It's not a straight line. And what that demonstrates is that the rate of desaturation is different at different points on the curve. If you look at the points where a PaO2 is 90, that curve is flat. Saturations are approaching 100%. Once the PaO2 gets below 60, and that roughly equates to a pulse ox of 90, itty-bitty drops in PaO2 are associated with huge drops in pulse ox. This is what we call the steep part of the curve. This physiologic curve manifests itself in our clinical practice. So if your patient has a pulse ox of 100% at the time of paralysis, they will slowly desat until they reach an SpO2 of around 93. And at that point, they desaturate faster and faster and faster. In other words, they fall right off of that curve. Now, if pre-hospital patients undergoing RSI intubation, 100% of them had peri-intubation hypoxia if their starting saturation was less than 93. This is an indication of how rapidly patients desaturate once they become hypoxic. In yet another study, patients with a starting sat between 98 and 100% had a rate of peri-intubation hypoxia of only 20%. So starting at 100% is no guarantee that you won't desaturate. You have to do other things in this bundle, but I'll take an odds of 20% of desat over an odds of 100% any day. So what this means is that patients with starting sats above 93 can typically tolerate a longer period of apnea without desaturation. This allows more time for a safe and controlled intubation attempt. So then it is predictable that patients with starting sats of less than 93 are at very high risk of peri-intubation hypoxia. In fact, this same study showed that 100% of patients with a starting sat of 93 or less desaturated during intubation, confirming what we saw with the other study. So preventing desat then is at least partially dependent on having good data on your patient's saturation, meaning you need pulse ox. Now, unfortunately, pulse oximetry data is not a foolproof technology. It has a tendency, especially in hectic intubations, to go walkabout. Of patients with TBI in this study who were undergoing RSI, 79% of them had at least one pulse ox dropout during the intubation. So what is a dropout? It means there was simply no oximetry value displayed. You're getting good data, poof, no more data, then good data again. Now, additionally, the actual value displayed, that's a bit delayed. In this study, 55% of intubations had an intra-attempt SpO2 low point, or nadir, that occurred after resumption of ventilations with oxygen. Now, we probably all experienced this. So you see a patient who is well saturated and you start to see the sats drop. You intubate and you have a beautiful end-tidal CO2 waveform. You visualize the tube going through the cords. You got great breath sounds. There's condensation in the tube. God himself comes down and says you are in the trachea. There is no doubt. Yet you continue to see the pulse ox drop. Now, that's not because the tube is in the wrong place. It's not because you're not using oxygen. It's because of pulse ox lag. There is just a delay between what is actually going on and what you're seeing on pulse ox. Now, fortunately, we can use this information to improve the safety of our intubations. First, do everything possible to assure the pulse ox probe is firmly affixed to the patient somewhere other than distal to the blood pressure cuff. And make sure it's not inadvertently dislodged. One of the things that we found early on as we're looking at our biometric data coming off of the monitor is that we would have this beautiful pulse ox reading and then we would lose it. And then it would come right back, beautiful pulse ox reading, and then we'd lose it. And then it'd come right back, beautiful pulse ox reading. Seemed very rhythmic, very cyclic. And that cycle just seemed to be occurring at a frequency of every 5 minutes. Almost like something was happening every 5 minutes. And it turns out that was the case. The pulse ox probe was distal to the blood pressure cuff, which was going up every 5 minutes. And we know that a blood pressure cuff turns into a tourniquet as the pressure is highest. No pulse oximetry. Now, we have also found that little clippy thing for the pulse ox, it comes unclippied pretty easily. Whether you kick the wire or whether the arm falls off, it's easy. Well, the arm probably wouldn't fall off. Maybe it would fall off the arm. It's easy to become dislodged in any case. There really is no perfect technology, but it turns out that if we're aware of it, it will dramatically decrease. Not perfect, but way better. Also, by the way, don't wait to abort an intubation attempt until the sats get below 90. Don't wait for them to become hypoxic because pulse ox lag, they're already hypoxic. We have to assume that because of this pulse ox lag, the patient is already desatted by the point they get to 90. The safe place then to bail out of an attempt when pulse ox starts to drop is below 94%. To fully maximize preoxygenation, we need to not only increase the SpO2 to 94% or higher, but we need to keep it there for long enough to completely fill up the patient's physiologic buffer. So in most healthy patients, this physiologic buffer is filled up by normal tidal volume breathing for 3 minutes, breathing normally at a normal depth and normal rate. So we need to raise the oxygen saturation above 93 and keep it there for at least 3 minutes. So the point of this exercise is to replace the inert gas in the lungs and in the blood with oxygen. Now, because the atmosphere contains 21% oxygen and 78% nitrogen, our lungs and our blood also contain 21% oxygen and 78% nitrogen. Now, remember that nitrogen isn't doing anything for us. It's just there. If you breathe 100% oxygen, you will come close to getting rid of all of the nitrogen and replacing it with oxygen in about 3 minutes of patients who are spontaneously breathing normally. Now, this process of gas replacement is called denitrogenation. That term, denitrogenation, is often used synonymously with preoxygenation. Now, keep in mind this 3-minute guideline is based on healthy patients. And as you probably know, we're not in the typical habit of intubating healthy patients. That means that while the 3-minute target is a reasonable starting place, it may not be the best measure available. In fact, it's not. Anesthesiologists measure effective denitrogenation by looking at something entirely different. They look at this thing called end tidal oxygen, or ETO2. That's the concentration of oxygen measured at the end of exhalation. It's the exact same concept as end tidal CO2, but with O2 instead of CO2. End tidal O2 values above 85% are typically considered markers of effective preoxygenation. Now, unfortunately, monitors that report end tidal oxygen, they ain't available in our environment. They ain't available in the emergency department either, for that matter. About the only places that I know that are actually measuring end tidal O2 in the emergency department are those doing research studies, like some of the ones that I'm about to tell you about. I'm hopeful, ever so hopeful, that we will be able to see this technology move into our field, hopefully sooner rather than later. So do me a favor, y'all. Do me a favor. The next time you see a monitor rep at a conference, they're showing off their new bling, please tell them, please add end tidal oxygen, not end tidal CO2. I know you got that already. Please add end tidal oxygen to allow better, more accurate preoxygenation and safer intubation. All right, so there's my plea. Hit up the reps. Maybe they'll give you some bling. Maybe they'll pay attention, but hit them up. Do me a favor, ask for it. Now, if the SpO2 level drops below 94% during the 3 minutes of preoxygenation, do something different to get the sats back up above 94%, and then reset your 3-minute time period. In other words, we need a full 3-minute period of sats at or above 94% to improve denitrogenation and to assure it. Likewise, if the sat drops below 94% at any point during an intubation attempt, bail out and do whatever is needed to get the sats back to 94 or higher, then reset your 3-minute timer before your next attempt. All right, so if peri-intubation hypoxia is common and it's harmful and we can predict when it will happen, how do we prevent that? Well, fortunately, the answer, it's not at all complex. You ready for this? Here you go. Stop intubating hypoxic patients. That's really it. It's that simple, not complicated at all. If you want to avoid peri-intubation hypoxia, stop intubating hypoxic patients. And that's the second point I want you to take away. Now, not intubating hypoxic patients does not mean don't ever intubate patients who were hypoxic. It means fix the problem first, then intubate. The common phrase for this is resuscitate before you intubate. I love that phrase, blatantly stole it from Dr. Weingart. Now, once you fix the problem, then continue with intubation. All right, y'all, so we're going to split this video into 2 parts right here. We're doing this to prevent decubitus ulcer formation. Those are bad. We don't like them. So go grab a drink, get some more popcorn maybe. Who knows, even run to the bathroom and get rid of your last drink. Join me back in part 2 for some more juicy science that demonstrates that the components of this DSI protocol really do work. Thanks, y'all.